let me start another topic, and that is encephalitis. These all are related topic. Okay, these all are different examples of CNS infection. So the understanding is a bit easier for you. Let's start with a case before we move further in encephalitis topic. Now all of you, please focus on your slide. Okay, I'll give you a bit of time to go through this, and definitely I'll explain. So see there, please. Now this case, okay, so let me explain this first and ask you the question later. A 35-year-old female presented to the emergency room with fever and a left focal seizure. So these are the chief complaint. That is the age, 35 year, she is female, and she presented with fever and a left focal seizure. She had been previously healthy, so no risk factors are there. But she developed fever and malaise just one day before the seizure episode. So very short history, very short. She started with seizure and fever, and that fever started just a day before the seizure. And what type of seizure? It's a focal one. Focal means partial seizure. When she arrived in the emergency room, she was disoriented with time, place, and person. And she had a fever of 39 degrees centigrade. So definite temperature rise is there. Other physical examination was unremarkable. You didn't find any other thing. There was no neck rigidity, no Kernig sign, no Brudzinski sign, no other neurological deficit. Okay. A CT scan of the head was done, and it showed a focal area of low attenuation in the right temporal region, but without brain shift. So something is wrong in the right temporal region. That's the information you get. Low attenuation means hypodense area. And there was no brain shift, means still the amount of cerebral edema is not that high, and it is not pushing the brain to other side. Now they have decided to go for lumbar puncture in this situation, and LP was done, and the CSF analysis showed 100 WBC with 100% lymphocyte, 100 RBC, protein was 100 milligram per deciliter, and glucose was 60 milligram per deciliter. Now inside the bracket they have given blood, okay, parameters like total serum protein 8 gram per deciliter, and this is blood sugar, this is normal in the blood. CSF gram stain and culture were both negative. So what is this infection? What do you think? What is the diagnosis?
Sir, it looks viral infection because of one day fever history, sir.
Okay, Mujib, you are saying viral infection. Good.
Increased lymphocytes also detect the viral infection.
Good.
Now the WBC and glucose are also a little bit elevated.
Good. Saddam, very good. Yes, Saif, you are saying something. What do you think?
Yes, sir. It looks kind of viral infection, sir.
So it looks like
meningitis.
Okay, so
it looks like meningoencephalitis.
It looks like meningoencephalitis. Okay. Now, all of you, please pay attention here. So let me elaborate this case. Definitely, it has a very short history, and the fever is also not that high grade. She was disoriented when she presented to the hospital. Okay, so let me analyze the symptoms and signs first. Okay, it looks like viral infection. You're absolutely right. But is it viral meningitis or viral encephalitis? And the answer is provided by disorientation. This is not very common feature in viral meningitis. It is very commonly seen in encephalitis though. Okay, and another important point, there are no neck rigidity, no Kernick sign, no Brudzinski sign. Though they are only present in 50% of the cases, they are absent. So that is strongly against the meningitis. Now CT scan shows definite pathology in the right temporal region, and CSF shows, okay, WBC are high and 100% lymphocyte. It also matching with the viral infection there. Okay, protein is elevated. It occurs in viral. There's no doubt. And glucose is normal. Yeah, though it is not, the blood sugar is not given here, but we believe it's around 80. If the blood sugar is around 80, then 60 is within the 2/3 of the blood sugar. So we consider that also as normal one. And there is no bacteria seen in the gram stain, and culture were also negative. If we combine all these things together, only one virus comes into our mind, and that is herpes simplex virus, HSV, because HSV causes temporal lobe infection of the brain, and the CSF analysis showed RBC in the CSF. This is the hallmark of herpes simplex encephalitis. Leakage of the RBC in CSF along with involvement of temporal area of the brain. Never forget these two important clues, and you can safely conclude this is a case of herpes simplex encephalitis. Now see here, acyclovir was initiated for presumed herpes encephalitis. CSF was sent for PCR polymerase chain reaction for HSV1 and HSV2, and it came out as a positive for HSV1. So this is herpes simplex virus 1 encephalitis. Viral culture of CSF was negative. So this is how we conclude or reach to the diagnosis. So with this good case, let's enter into the topic. Now, what is the definition of encephalitis in the beginning? Encephalitis is an inflammation of brain parenchyma. See there? Inflammation of brain parenchyma is encephalitis. Now, sometimes it may be associated with meningitis also, and during that time we call it meningoencephalitis. You can see it here, meningoencephalitis, both of the situation together. It can present as a diffuse or a focal neuropsychological dysfunction. Usually diffuse is more common than the focal. Acute encephalitis with a short duration is most commonly a viral infection, and in that situation there is parenchymal damage from mild to profound. Sometimes the person will recover without any neurological sequelae, but sometimes even if the patient survive, okay, there would be long-term neurological sequelae in the patient. Sometimes they may lose vision, sometimes they may lose hearing, sometimes there may be some paralysis of the body, so something like that. Another type of encephalitis or encephalopathy is subacute and chronic encephalopathy, and the most likely cause is toxoplasmosis in immunocompromised patient, which is a bit rare. It only occurs in immunocompromised situation like AIDS. Let's move on now. Now, what is the pathophysiology of encephalitis? How these viruses or other pathogen they enter into the brain? Viruses are the most common cause of encephalitis. We already know that, and we'll list what are those viruses a bit later. They can occur either as a direct effect of an acute infection or as one of the sequelae of a latent infection. Now, when the acute viral infection is going on in the body, that time encephalitis may happen, or patient has got better from that acute infection of the viruses. Later on, after a few weeks, after a few months, or even after a few years, okay, the viruses which are there hidden in the body, this is called latent viruses, they can become active again and can cause the infection. So this is another mechanism. In general, the viruses which replicate outside the central nervous system and they gain entry either by blood spread or by traveling along some neural pathway, and these are the good example: rabies virus, HSV, and varicella zoster virus. And through the olfactory HSV, okay, this neural means uh, through any nerves, any cranial nerves or any peripheral nerves, and this olfactory is definitely olfactory nerve. It's a cranial nerve 1, isn't it? So these are the different examples. So rabies virus, herpes simplex virus, and varicella zoster virus, all of them can enter into the brain through the neural pathway. Whereas there is one condition known as subacute sclerosing panencephalitis. Now let me underline this because this is a very important question in the MCQ exam. Subacute sclerosing panencephalitis. This is a long-term complication or very late complication of measles. This is a complication of measles. It occurs many years after the primary measles infection, and we really do not know what is the pathophysiology of SSPE, but this is called degenerative brain disorder. In that condition, the brain cells, okay, they are dying away, the number is decreasing. So this person is suffering from neuropsychiatric manifestation in SSPE, and sometimes they may die as well. Okay, so these are some other sort of mechanism for encephalitis or encephalopathy. Now let's talk about what are the vector or how these organisms damage the brain. Herpes simplex virus lying dormant in the trigeminal ganglia. Now where is trigeminal ganglia? Where it is present?
Fifth cranial nerve.
Okay, it is associated with fifth cranial nerve. Good. It is present in the head and neck area. You can say like that. Okay, in head and neck area, in the trigeminal cave. That is the area where it is located. It is a very big ganglion, and from this ganglion, the 3 branches of trigeminal nerve will emerge. And what are those 3 branches?
Ophthalmic, maxillary, mandibular.
Very good. Ophthalmic division, maxillary division, and mandibular division of trigeminal nerve. Okay. Now let's come to the point. This herpes simplex virus lie dormant in trigeminal ganglia and in other ganglia as well. Mosquitoes or ticks, they inoculate arbovirus. So mosquitoes are the carrier or the vector for arbovirus. Now, one of the important type of arbovirus is Japanese encephalitis virus, JE virus we say, and this is very common in tropical countries. Even in South Asian countries, it is quite common cause of encephalitis. And Culex, a mosquito, is the vector for that particular virus. Rabies virus is transferred by animal bite. Dog bite, okay, is the most common. Dog is the most common animal which is implicated here. But some wild animals can also, okay, lead to rabies. Like even bats are responsible for the rabies. Varicella zoster virus and cytomegalovirus may occur in immunocompromised host. Definitely. There is presence of negri body in case of rabies. These negri bodies are the pathognomonic features of rabies. That means after the death of that animal or that person, if we take the brain biopsy, we can see this negri body. They are eosinophilic, cytoplasmic inclusion body, and mainly present in hippocampus and cerebellar area. Whereas in HSV infection, we get a Cowdery type A inclusion body. These are eosinophilic but intranuclear inclusion body, and they are mainly present in the temporal and orbitofrontal lobe, mainly in the temporal lobe, okay, because that is the area which is infected by HSV virus. Cowdery type B occurs mainly in adenoviral infection, and B is the term we use for basophilic inclusion body. A is the term we use for acidophilic inclusion body. Let's talk about the causes of viral encephalitis now. Which are the viruses that can lead to encephalitis? Please mute yourself. The most common causes of acute viral encephalitis are rabies virus, which is a very lethal type of viruses. If there is a clinical rabies occurs in a patient, there is 100% mortality. There is 100% mortality after a clinical rabies. Another important virus is herpes simplex virus or HSV. Poliovirus can also lead to both meningitis as well as encephalitis. Measles virus, we just talked about. SSPE is a type of long-term complication, a very late complication of measles virus. That's the type of encephalopathy. And even John Cunningham virus or JC virus, which belongs to polyoma virus, can lead to encephalitis. Okay, so please mute yourself, guys. Now, other causes include infection by arbovirus family like flaviviruses and toga viruses. Flavivirus, some of the important examples are Japanese encephalitis virus, St. Louis encephalitis virus, or West Nile viruses. Among them, Japanese encephalitis virus is present all over the world, very, very common in Asian countries as well. Toga virus or Toga viridae, the examples are Eastern equine encephalitis virus and Western equine encephalitis virus. This equine term is for the horse. So these viruses, the mainly, they are found in the horses, and they are mainly present in the United States. Among the bacteria and other pathogens which cause encephalitis or encephalopathy, let's talk about them a bit. Bacterial meningitis, if it spreads directly onto the brain parenchyma, it can also lead to primary encephalitis. But the chances are not that very common. Syphilis, which is a sexually transmitted infection caused by Treponema pallidum, can also lead to encephalitis. Toxoplasma, this is a type of protozoa. It usually causes infection in immunocompromised people, can lead to encephalitis. Cryptococcus neoformans is a yeast. It also causes infection in immunocompromised people. It's a type of fungus. And another important cause may be granulomatous amoebic encephalitis like acanthamoeba and Naegleria. These are the two important types of amoeba which can also leads to inflammation of the brain. So these are some other pathogens apart from the viruses. Now, after knowing the names of the causative agent, let's talk about the mode of transmission. Okay, mode of transmission, how a person gets encephalitis. The viral agent like HSV type 1 and type 2, HSV type 1 and type 2. Now see there how they enter into the brain. They enter into the neuronal pathway we have just talked about. They can enter during the active infection, or they can enter as a latent form also. Varicella zoster virus, Epstein-Barr virus, measles virus, mumps, and rubella are spread through person-to-person contact. If one person is getting this infection another person can easily get through the contact, and then the natural infection occurs in the body, and one of the modality of that infection is encephalitis. Important animal vectors include mosquitoes, ticks, and warm-blooded mammals, especially dog in case of rabies. Mosquito is a very important vector for Japanese encephalitis. Okay, ticks for some other forms of encephalitis, like which we have just mentioned, different forms of equine encephalitis and those things. West Nile virus can be transmitted by means of organ transplant or blood transfusion. This is not very important for us, okay? For us, the mosquito and the ticks are the important vector, and don't forget dog as the very important vector for rabies. Now, what is the importance of this topic? What is the chance of mortality and morbidity of encephalitis? See here. If herpes simplex encephalitis is untreated, the mortality rate is very high, 50 to 75%. This is massively high mortality rate. And 100% of them have long-term motor and mental disability. So what's the lesson we have learned? We have to diagnose this condition quite early and go for the proper management. This is for herpes simplex virus. And we have drugs, fortunately, for herpes simplex virus. For so many other viruses, we don't even have antiviral medicine. Rabies encephalitis and acute disseminated encephalitis are virtually 100% fatal, though the medical literature include reports of survivor. Regarding rabies, okay, the different literature, when we go through them, one survivor has been reported. But still, if you follow different textbook of medicine, it is clearly written, it is 100% fatal disease. Now let me say a bit about it, okay? When a rabid dog bites a normal person, there is certain incubation period for the rabies. During that incubation period, if a person takes vaccination or protects or prevents himself from the clinical diseases to occur, the person will be safe. But once the signs and symptoms develop in that patient, the patient is going to die. We cannot save that patient. That is the meaning of 100% fatal. Don't think after the bite of a dog, 100% of the people are going to die. The meaning is not that, because till now the disease has not happened. Now, with this information, let's talk about what are the clinical features of encephalitis. See here. This is mainly caused by viruses, and viruses have viral prodrome. This viral prodrome lasts many days, okay, before the real encephalitis occur. And these viral prodrome include fever, headache, nausea and vomiting, lethargy, myalgia, okay, some sort of sore throat, some runny nose, moist eye, and this type of thing. In some people, even rashes may be there. This fever is a low-grade fever. So remember, any type of viral infection is having this viral prodrome. Now, the classical presentation of encephalopathy with diffuse or focal neurological symptoms include the following. And usually, in case of encephalitis, these are the common symptoms. The patient may be having behavioral and personality change. Behavioral and personality change. Let me underline this for you. There is decreased level of consciousness, very, very important point. The person may be disoriented, the person may be drowsy, the person may be somnolent, the person may be having stupor, or the person may be in coma. These are the different points. If it is meningoencephalitis, there may be stiffness of the neck, there may be photophobia, and lethargy is a common feature. The person may be having generalized or partial seizure. If multiple area or large area of the brain is affected, there is generalized seizure. Otherwise, there may be a focal seizure. So please mute yourself. Okay. Another important point is acute confusion or amnesic state. This acute confusional state is called delirium. Delirium. And amnesic, this is retrograde amnesia or anterograde amnesia. Retrograde means in the past the person forgets everything of the past, and anterograde means the person do not have that memory. Okay, from the time of the disease onset, whatever happens the person will forget. This is anterograde. These are different type of amnesia, loss of memory. Flaccid paralysis can also occur in the patient. Okay, flaccid paralysis. This is acute flaccid paralysis. This is not very common type of manifestation, because let us remind what do you mean by upper motor neuron type of lesion. In upper motor neuron type of lesion, what happens in the beginning? Okay, there is flaccidity of the muscle for certain duration. Later on, that flaccidity will be converted into spasticity, because spasticity is the hallmark of upper motor neuron lesion. We are talking about brain disorder, encephalitis. This is upper motor neuron lesion. So this flaccidity only occurs in the initial period. Later on, it is replaced by spasticity. Let's move on. Okay. Now, less common symptoms include complaints of meningismus, which usually occur in meningoencephalitis. I've mentioned this so many times. If neonate are having HSV infection, now how neonate gets HSV infection? What is the
Sir, from the mother during birth.
Exactly, from the mother during birth. If mother is carrying this HSV infection in the genital region or in the vulval area, then the neonate may get it. Now see there how that neonate will manifest. Skin, eye and mouth lesions are the early presentation in that neonate. So eye is one of the very important organ which is affected by herpes simplex viral infection. There will be ulcer formation in the cornea. So this is one of the important cause of corneal ulceration. Different terms are there like geographical ulcer, dendritic ulcer and things like that. You will study this in ophthalmology. Regarding the skin, there will be vesicular lesion. Vesicle are fluid filled lesion which are smaller than 5 millimeter in size, and sometimes even inside the oral cavity the lesions are seen. Another form of neonatal HSV infection is encephalitis. That's what we are talking now. That neonate will have decreased level of alertness. The neonate may be drowsy a bit, irritable. There may be seizures, sometimes uncontrolled seizure or intractable seizure, and it is very difficult to feed that neonate. Poor feeding is a feature of encephalitis. Bulging fontanelle. Now every student can answer. What is the reason for this bulging fontanelle? Why?
Because of
Pressure will be increased in the
front
nasal
breast
fossa.
ICP, sir. Breast ICP.
Exactly. Because of encephalitis, there is cerebral edema. Because of cerebral edema, there is res ICP, and that res ICP is manifested as bulging fontanelle, because we are talking about neonate now. Sometimes some of the neonate may present with widespread disseminated disease, and they can also present with DIC or shock. DIC is one of the manifestation of severe type of neonatal HSV infection. Okay, so let's move on. Now, what are the signs of encephalitis? As a doctor, when we examine the patient, these are the different signs we may get, and these signs may be diffuse or focal, especially in herpes simplex virus encephalitis. This is a focal finding. And out of the different areas of the brain, temporal lobe is most commonly affected by herpes simplex virus encephalitis. That's why it is written as a focal finding here. So don't forget that. Now see here, what are the signs? There may be altered mental status in the patient, which we detect by Glasgow-Coma scale or AVPU scale. We have to assess that when the patients are admitted in the hospital. And if Glasgow-Coma scale is less than 8, we call that coma. Regarding the focal findings, the patient may be having hemiparesis, focal seizure, and autonomic dysfunction, and that also we detect by examination. Hemiparesis is weakness of one side of the body. Movement disorders can also be there, which are more common in St. Louis encephalitis, Eastern equine encephalitis, and Western equine encephalitis. They are more common in North America, okay, that continent. And that movement disorders can be different examples. Can you tell me some of the different terms we use for movement disorder? Yes?
Korea, sir.
Korea,
Korea.
Hypokinesia,
Good.
hyperkinesia,
Dyskinesia.
dyskinesia, dyskinesia,
heavy
Nice.
bilismus.
Okay, very good. So different answers are coming.
Cardio dyskinesia.
tremors,
So let me, repeat those again, which is told by different students. Tremor, very good. Tremor, then chorea, hemibalismus, okay, dystonia, isn't it? These are the different types of movement disorder. So any of those may be present in case of encephalitis. That's why it is a very serious type of infection. Patient may be having ataxia. Ataxia means if cerebellum is damaged, then the person cannot walk on a straight line. The person sways here and there. That is called ataxia. Cranial nerve defect is quite common. Any cranial nerve can be involved. So we have to examine the cranial nerve quite well. Dysphagia, okay, we can give a glass of water if a patient is having rabies and check for the this dysphagia. So what is the another term for this? Hydrophobia, right? Okay, you probably have not gone through the discussion of rabies. This is known as hydrophobia. The rabies person, if we give water or even show water to them, they are afraid of that because they cannot even drink the water. This situation or condition is known as hydrophobia. So that's how we can judge they are having dysphagia. And meningismus, okay, is less common and less pronounced than in meningitis because mainly the brain parenchyma is affected here rather than meninges. But in meningitis, meninges are mainly involved. That's why the extent or grade of meningeal irritation signs are much more higher in meningitis than in meningoencephalitis. Let's move on. Now let's talk about the differential diagnosis of encephalitis. Now just run your eyes through this list. Now all those diseases we have included before also. Brain abscess, subarachnoid hemorrhage, meningitis, status epilepticus, tuberculosis, and hypoglycemia. You can include so many others there, okay? These are not the only differential diagnosis. And again, the same question may be coming. What are the differentiating feature between brain abscess and encephalitis? How you separate subarachnoid hemorrhage from encephalitis? How status epilepticus is a differential diagnosis of encephalitis? Now what happens in status epilepticus? the patient will lose consciousness. In encephalitis also, the patient may lose consciousness. But in status epilepticus, after certain duration, the patient will wake up. But here, it may be prolonged type of loss of consciousness. And when I go to the etiology, the etiologies are very different. Hypoglycemia can cause loss of consciousness because of cerebrogleukopenia, which is seen in severe hypoglycemia. That's why it is considered as a differential diagnosis. Now, what lab test you like to order? Just have a look here. We start with CVC and differential because this is a type of infection. So we always start with CVC in a case of infection. Now, what is the interpretation when the report comes? The WBC count is normal or slightly high, whereas the differential count shows lymphocytosis. The percentage of the lymphocytes is more. Serum electrolyte we routinely do in any case of central nervous system disease or infection. Now, there is one important relation here, and that relation is SIADH. In case of central nervous system pathology, syndrome of inappropriate ADH secretion is very common. Now, what happens in sodium level in case of SIADH? What happens to sodium?
Dilutional
Hyponatremia.
Dilutional hyponatremia.
Dilutional, so the
Very good.
sodium will be lost.
Very good. Dilutional hyponatremia. Okay, dilutional hyponatremia. Never forget it. And the mechanism for this is that ADH is retaining only water, and that water will dilute the amount of sodium which is already present in the plasma. This is the mechanism. And treatment is also very easy. Regarding the treatment, you need to restrict fluid. You just give 2/3 of the maintenance fluid in this situation. Now, serum glucose level is always done. Okay, it is always done in this case. And if somebody asks you, how do you explain it? You just say hypoglycemia can lead to loss of consciousness, can lead to seizure. It is considered one of the differential diagnoses of encephalitis. That's why I am ruling out hypoglycemia by ordering blood glucose or serum glucose level. BUN and creatinine, these are renal function tests. Now, even in renal failure, there is encephalopathy occurring. The brain is, affected by those toxins which cannot be excreted outside the body. So we have to rule it out. Liver function test, same explanation you can give. Hepatic encephalopathy can lead to, damage of the brain. So just rule it out. So what are the liver function tests? What are the different things we do here?
Sir, we can do enzymes, different enzymes. We can do PT.
Very good. Very good. ALT
Later,
and AST
AST.
and ALP. Okay, these are the three
Albumin level.
important enzyme. Excellent. Another is albumin level. Very good.
Prothrombin time.
Prothrombin time, PT. Okay, and then bilirubin.
Bilirubin.
Exactly. If you answer this much, okay, we are quite satisfied. These are the most important part of liver function test. And if the liver is badly damaged, they will definitely give you some clues or some hint. Urine or serum toxicology screening is ordered if you believe, okay, it is caused by poisoning or toxins, especially the loss of consciousness is caused by poisoning or toxin exposure. But in a pure cases of encephalitis, this lab study is not necessary. Now, what are the other lab studies? These are the basic or general studies, isn't it? So what are the other specific type of study? Now, please pay attention. If you believe this is herpes simplex virus, you have to or you can go for PCR. polymerase chain reaction to confirm it. Take a CSF after lumbar puncture, and in that CSF go for PCR for DNA of herpes simplex virus. If it is present or if it is positive, you can confirm the diagnosis. Viral serology, okay, can be done, and complement fixation antibody can be detected in different viral infection. Heterophile antibody and cold agglutinin test can be done for Epstein-Barr virus. You have studied Epstein-Barr virus before, and in Epstein-Barr virus there is heterophile antibody present. Now, this heterophile antibody means this antibody is against heterophile antigen, and that heterophile antigen may be present in different species. Okay, similar type of antigen may be present in different species. So we take antigen from that one of that species, and we take a plasma or serum from the patient, mix it together. If it is positive, then we may believe Epstein-Barr virus infection is there in the patient. Now, what is cold agglutinin? What do you mean by this?
So the antibodies just respond to cold weather.
Exactly, you're right. The antibody which react in cold temperature. The antibody which reacts in cold temperature is called cold agglutinin. These are usually IgM type of antibody. Now, can go for serological test for toxoplasmosis as well. These are different types of lab study. Now, another sort of test or lab studies are imaging study. So we have to perform CT scan of the head or MRI. If CT is not that confirmatory, or if you still believe some other pathologies are there, you can go for MRI. Search for evidence of elevated intracerebral pressure, obstructive hydrocephalus, or mass effect by CT scan. You can rule out other differential diagnoses as well with CT scan of the head. In toxoplasmosis, which is one of the differential diagnoses, we can see ring enhancing lesion, which we just discussed, okay, in the topic of brain abscess, because toxoplasma can also have a nodular type of lesion there. But remember one thing, this nodular or ring enhancing lesion cannot be seen in plain CT. You have to do contrast enhanced CT to see this. Now, the last part of the discussion is treatment. Now, this encephalitis is a very serious disease. Usually, the patients are in coma. Now, in a comatose patient, I will take a class maybe later on, okay, when a particular time comes, how to manage a coma case, but many of the students already know. In a coma case, we always start with A, B, and C, because coma patient, they cannot protect their airway, and they may die if we pay attention to management of other things. So airway protection has to be done with endotracheal tube intubation, and preferentially the cuffed endotracheal tube is inserted. After that, okay, focus on breathing and then circulation. Now see here. Evaluate and treat for shock or hypotension. Give crystalloid until the patient is euvolemic. Now, all cases of encephalitis may not be in shock, but extensive type of herpes simplex virus infection or widespread type of infection can result in septic shock. So we need to manage accordingly. Already talked about airway protection. Consider seizure precaution, and if seizures are already there, go for the treatment. Now again, the two types of discussion will come here. If patient is developing ongoing seizure in front of you, the patient is seizing in front of you, the drug diazepam or benzodiazepine has to be given to control it quickly. But for the long-term control of the seizure, benzodiazepines are not used. Remember that. We need to use for other medicine, okay, like phenytoin, phenobarbital, valproate, or even carbamazepine, or even the second line drugs you can go for. Stabilize the alert patient with normal vital sign by administering oxygen, securing IV access, and giving necessary treatment. These all are called symptomatic and supportive therapy, because many of the viruses which cause encephalitis, they do not have antiviral treatment. No specific treatment. So how we treat the patient then? If the patient is in coma, take care of the coma. If patient is hypoxic, give oxygen. Secure IV line, give IV fluid through that, because patient cannot drink in a comatose case. Okay, so all these important therapies are provided in the hospital, and this patient should be in ICU. This patient is very sick, preferentially in ICU if the beds are available. Now, with the important exception of HSE and varicella zoster encephalitis, most of the viral encephalitides are not treatable beyond the supportive care. That's what I was talking right now. So, fortunately, we have medicines for herpes viruses. Okay, we have medicines for herpes viruses, and that is acyclovir, okay, valcyclovir, and those type of drugs. But for many other, we don't have. Like Japanese encephalitis, we don't have any medicine. Rabies, once it occurs, we don't have any medicine. So that is the point. Treatment for Toxoplasma gondii and cytomegalovirus encephalitis are available. Okay. Now, Toxoplasma can be treated by sulfadoxine and pyrimethamine. These are antibacterial agent. And cytomegalovirus is treated by which medicine? Anybody? Any drug you know?
Gencyclovir.
Good, very good, Saddam. One more drug. Anybody?
Fusarinide.
Now, for cytomegalovirus, okay, let me write that one for you, because sometimes this type of questions may be asked. The drugs for cytomegalovirus are ganciclovir, okay, ganciclovir and foscarnet. Okay, foscarnet. There are so many other drugs. You can go and check the pharmacology textbook for that, but these are quite easy to remember. The goal of treatment for acutely ill patient is we give first dose of acyclovir, with or without antibiotics or steroid as quickly as possible within 30 minutes of the arrival. Now, a question should come in your mind here. Why did they mention antibiotics here? Because this is mainly caused of viruses, isn't it? So the answer is a bit practical here. In the beginning, probably because of the very serious situation of the patient, we should consider that, and we are not sure whether this is a bacterial infection or a viral infection. So to be on the safe side, use a broad spectrum antimicrobial agent along with acyclovir, okay, especially if a patient is in coma, for example. If there is no high grade fever, you know this is a case of encephalitis, but you are not sure, okay. Strong index of suspicion is towards encephalitis, but a little bit doubt is still there with bacterial infection. So cover that with antibiotic as well as acyclovir, and better to give steroid to decrease the chances of inflammation. Now, how to manage the related, complications? See this, if hydrocephalus has already occurred, if raised ICP is already there, then we go for symptomatic and supportive therapy. Try to decrease the pressure during that time. So which medicine you want to give to decrease this raise ICP. Which are those medicines?
Mannitol,
Diuretics.
corticosteroids.
We can do.
Exactly. Okay,
We can put
mannitol.
sir.
Very good. We can go for mannitol. We can go for corticosteroid like dexamethasone, isn't it? You can also go for furosemide, and you can also go for shunt therapy if this is hydrocephalus. Excellent answer. And one more you can include there. You can go for mechanical ventilation, and you can wash out that excessive carbon dioxide, because carbon dioxide or hypercapnia is exacerbating cerebral edema. And these days you can also go for cold therapy. Expose that brain or head to the cold temperature, and if inflammation is going on inside, it will help the patient. Systemic complication should be looked for and treated if any. If septic shock is there, you go for the treatment of septic shock. If DIC is there, go for the treatment of DIC. Now, how to treat DIC? What type of medicine we give?
Sir, we can
Heparin.
give fresh frozen plasma, sir.
Okay, good. Fresh frozen plasma or heparin. Okay, very good answer. Excellent. So these are the drugs we give for the treatment of DIC, but better try to find out the cause of DIC. DIC is not a primary diagnosis, it's a secondary diagnosis. Something must be there to cause this, So try to find out that cause and go for the treatment of the primary cause. Meanwhile, you can control the different problem in DIC. And what about septic shock management? What is the first thing you like to give in septic shock?
Electrolytes.
Adrenaline, drug
Very
of
sure?
choice.
Anti-histamine.
Okay, so let me give you, we have a very, just 1 minute time left. So let me give you some important answer here. In case of septic shock also, the first thing is IV fluid. Never forget it. Though it's a type of distributive shock, the fluid is redistributed in the body, but still the arterial system is having decreased amount of volume. So we give a lot of fluids. Okay, along with fluid, we give antibiotics or antiviral agent, whatever is the cause of septic shock, but better to give both if you are in doubt. Use some vasopressor medicine to bring that blood pressure back towards the normal, like dobutamine, dopamine, even adrenaline or noradrenaline can be tried.